So, when we think of the word psychopathology, what comes to mind? What comes to mind when you think of psychopathology?
Some kind of related with the mental, like with mind, brain.
Something related to the mind or the brain? Okay. Any other thoughts? How about I ask it differently? If you look at this word psychopathology and you wanted to divide it into parts, and I'm going to say divide it into three parts, better yet. Where would you draw the line in the word?
Between psycho and pathology.
So psycho and pathology. And if you wanted to do another division in the word pathology, how would you divide there?
Between path and ology.
Okay, right? Path or patho, and then we would recycle the O in ology. Yeah. So the reality is, in order to understand what psychopathology is, we can actually draw lines and break the word into its parts. So psycho refers to coming from the mind, as was described by one of your peers. Psycho is not meant to mean crazy, it just means mentalistic, right? So I know that people will misuse the word psycho as implying craziness or whatnot. Patho, when you hear patho, what is patho?
It's like the way how it affects the how it make the disorder occur, like to see how it's occurring in
So,
someone's.
yeah, okay. If someone experienced or had a pathogen, and you heard the word a pathogen related to a medical condition, what is a pathogen?
Pathogen is something that threatens the body. It's like it
Mhm.
enters the body and it affects it, and
Yeah,
in a
so
bad way, so the body could defend.
right on. So patho or pathos is some form of abnormality, right? So in the sense of a pathogen, it's some kind of entity that threatens the body. That's true. But a pathos is some form of abnormality. Ology, which most of you probably have heard of before. What is ology?
The study of.
Right on. Thank you, Teresa. The study. So if we were to take this word, we would put it into three parts, and we would say that this word means that we are going to be all semester long studying abnormalities as it relates to the mental condition. So you might say this is a psychological study of mental illness or psychological disorders. There are different ways to say it, but looking at the word, it makes sense that we're going to be looking at abnormal mental states. And the word abnormal just means not normal, right? And we're going to continue our discussion further. Abnormal, the word normal is a pretty broad term. So we'll talk about that as well. So let's get started. You might ask yourself, who is at risk for psychopathology? The answer is everybody. Everybody has some level of susceptibility to mental illness. It targets the rich, it targets the poor, right? So if you were to think of even musicians, right? So Kanye West, right, has a very public struggle with bipolar disorder. But it's not just Kanye West. There are many others. Britney Spears has struggled with mental illness, and so forth. So the idea that having money will protect you from mental illness, it's not true. It's just not true. So for what money does, it doesn't help you against mental illness. So no matter what financial status you're in, you are susceptible to mental illness. What I will say, though, in all fairness, is that being poor, so to speak, or in the lower socioeconomic status does increase stressors on a person. And stress is the universal trigger to mental illness. So if a person has stress regarding, are they going to be able to pay their rent? Are the lights going to be turned off? Is their car going to be repossessed? That stress could affect the person and trigger some level of a mental illness. So my point in saying it affects the rich and the poor is that the rich are not immune to it. You could be a public figure or the average person, or what we call the average Joe or Jane. So we see actors struggle with this. If we were to think of actors, can you think of an actor who might have struggled or struggles with mental illness?
Robin
Robin
Williams.
Williams.
Robin Williams is a classic example, right? So what a brilliant mind, but the struggles with depression and alcoholism caused him to take his own life, right? So people like Robin Williams, and that's just one example. How about writers, authors? Well, we know people like Walt Whitman, Ernest Hemingway, and so forth struggled with mental illness. Politicians, we know people like Abraham Lincoln struggled with depression, and so forth. So it doesn't matter whether you're living your life pretty much private or whether you're a public figure, you are susceptible to mental illness. Gender, men and women are susceptible to mental illness. Now, what's interesting about this is that there are some conditions where males have higher rates of certain psychological impairments, and in other conditions, women have higher rates. So when it comes to things like mood and affective conditions, we'll see that typically females will have higher rates of diagnosis. When it comes to cognitive conditions, things like ADHD, autism spectrum disorders, and so forth, we will see that males have higher rates of these conditions. Another dividing line between males and females will be conditions that are more internalizing versus externalizing. So internalizing conditions, things like anxiety or mood conditions, females will have higher rates typically, whereas externalizing things like conduct problems, aggression, we'll see males have higher rates, and so forth. And then obviously, when we look at various ethnic groups, all ethnic groups are susceptible to mental illness. And depending on the condition, we'll see that certain ethnic groups will have higher rates than others. So for example, let's take an alcohol use disorder. If I were to ask you which ethnic group has the highest rate of alcohol use disorders, who would you say? Who would you say has the highest rate of alcohol use disorders? Which ethnic group? And it's okay if you're incorrect. There's nothing wrong with being wrong.
Europeans.
So one answer being presented is Europeans. That's not quite right. Any other thoughts?
Hispanics.
Not quite right.
Native Americans.
Who said it? Native Americans.
Yeah, I said it.
Right on. So good job. So Native Americans or Indigenous Americans have the highest rate of alcohol use disorders. That does not mean every condition Native Americans have the highest rate, but that's just an example. So what is the point I'm trying to make with this slide? The overarching point that I'm trying to highlight is that no one is immune. You could be the most brilliant, charismatic person in the world, and you can struggle with mental illness. And in fact, it's roughly 1 in 4 to 1 in 5 adults struggle with mental illness across their lifespan, roughly. So in this class, one could argue that there are at least 4 to 5 people in this classroom that probably are struggling with one psychological disorder versus another. I see something in the chat. That is a very high rate, but that is the reality of things, right? So in this class, there might be 4 or 5 people. Now, mental illness is not a synonym for psychosis. So one of the reasons why people do not seek treatment is the stigma around mental illness. So psychosis occurs in roughly 1% of all mental illnesses, right? So having a psychotic condition is actually fairly low. So most people are struggling with some form of mental illness that is non-psychotic. So I'll give you some. If a person is struggling with generalized anxiety disorder, that is a mental illness, but it has no connection with psychosis. Now, can a person have a psychotic state? Possibly, yeah, but it is not by definition a psychotic disorder. A person struggling with major depressive disorder, ADHD, autism spectrum disorders, an eating disorder, right? And I'm just listing a whole bunch of conditions. You will see these are not, by definition, psychotic disorders. Can one have a psychotic break with any of these conditions? Perhaps, yes. But like I said, I don't want us to use the term mental illness and psychosis synonymous, or what people will colloquially say, crazy, right? So one of the reasons why people won't seek treatment is they'll say, I don't need help, I'm not crazy. And the reality is that even if a person struggles with mental illness, we're not saying that person is psychotic. We're not saying that person is crazy, so to speak. We are just saying that they're struggling with one psychological condition or another, right? So I'm starting very early trying to break the stigma of mental illness. Anyone have a thought or reaction to that before I move to the next slide? Okay, so let's continue. So if you were to ask for a blueprint of when we say we're trying to study mental illness, right? Mental illnesses. In order to have a psychological disorder, a person must have the 4 Ds. Now, I will say the first 3 are present in all psychological disorders, and the fourth D is present in some. So the 4Ds as a blueprint to mental illness are deviance, distress, dysfunction, and danger. I'm going to go through all of these and kind of unpack them further. So what does it mean to be deviant or to demonstrate deviance, right? So this refers to some pattern of behavior that's either different, unusual, bizarre, or extreme. So something that seems abnormal or not normal. Now, I said to you, the word normal is a very broad sense. There's a broad sense when we use the word normal, because norms are culturally dependent. And that which is considered acceptable in one culture may be different than in another culture. But before we consider a person's behavior different or abnormal, we have to understand their culture, right? So, but just as a definition, norms refer to either the explicit or implicit rules of society. For example, one of the norms that we have in US culture is that when you leave the home dressed. Typically, we wear clothing, right? And the amount of clothing we might wear might be different if we were in another society, right? Another example of norms in the US society, we tend to be more individualistic. And what does that mean? To be individualistic is we tend to focus on personal growth, reaching our potential, standing out, trying to be unique, and so forth. However, there are many parts of the world that are more collectivistic. And the idea of standing out and drawing attention to oneself is dishonorable. The idea of choosing one's personal goals over the family and the community is dishonorable in certain societies. So before we even think about labeling something as deviant, we need to understand the culture, right? The culture a person belongs to. So what do we mean by culture? These are the common values or experiences or rituals or habits or art or artifacts, for that matter, that a group of people share, right? So being aware of this is important. Now, what's interesting with the DSM is that we have a section in the DSM called culturally dependent syndromes, right? Which means that there are certain conditions that only show up in one community, and it's not generalized. So we are careful not to diagnose a person with a psychological disorder if it's culturally dependent. We have to assume that this would be considered atypical even through the lens of culture. So is that clear? So the first step or first element of categorizing a disorder is that the behavior has to be unusual, abnormal, atypical, however you want to say it. And we judge that relative to the society the person belongs in. Now, distress. Distress is the second of the 4Ds. So distress typically is that whatever the person is struggling with causes them to be bothered, causes them to be upset. It affects some level of social functioning, whether it be relationships and so forth. And I'll get more into that shortly. But the person is bothered by what they're doing. Now, I would argue in the vast majority of conditions, The person knows that they're struggling. There are some conditions where the behavior is unpleasant to those around the individual. For example, if a person is struggling with a substance use disorder and they're in what we would call the pre-contemplation phase, they might say, I don't have a problem. I can stop anytime. Mind you, this person who believes they don't have a problem might be stealing from family members, whether it be money or objects, and selling them so that they can fuel their substance abuse. So it is possible in some cases that distresses to other people. All right. Now, not every behavior that is considered deviant, we would say causes distress, right? So not every atypical behavior is distressing. For example, you might have heard of the Polar Bear Club. You might have heard them referred to as the icebreakers, right? And these are people who get a thrill from going into freezing or frigid water. Now, to be an icebreaker, is that the norm? Do most people enjoy going into freezing cold waters? Probably not, right? So it is deviant. That is not what people typically do. But is it distressing? So the people who are icebreakers or people who are part of the Polar Bear Club, and I know on New Year's Day in Coney Island, they have the Polar Bear Plunge every New Year's Day. And people line up, they pay money to do this. If you were to ask a person who's doing the Polar Bear Plunge, is this bothersome to you? Does this cause some level of distress? The average person will say, no, it's exhilarating. It's invigorating. It gives me a sense of euphoria. So the distress factor is gone. So would we suggest that people who do the Polar Bear Plunge have a psychological disorder? The answer is no, we wouldn't. So my point is you need all of the Ds, right? All of the Ds, certainly the first three. Okay, so the icebreakers, although it's abnormal, it is a social experience. It is considered, a community-based thing, and it's non-distressing. George.
I have a question. Sorry to interrupt.
Not a problem.
So basically, I know, I've read that polar plunges, they have health benefits to the body. So some people tend to do it purposely for health benefits, the outcome from it.
Yeah.
So I don't know, when do we consider it abnormal? Is it when people do it all the time, or
Mhm.
does it depend on the duration of the action, or does it depend on like I didn't understand why is it kind of
Yeah,
abnormal
so
behavior.
we're actually saying those people who engage in Polar Bear Plunge, it's not abnormal. We're saying that you'll see thousands of people, I kid you not, in Coney Island lining up to do the Polar Bear Plunge. It's not abnormal. It's a community-based event, and it does not cause distress, right? Now, you ask an important question about cold baths and hot baths. The concept of cold baths and hot baths or bathhouses, they have been around for thousands of years, and that's why I love the question. If you go to ancient Rome, they would have massive structures with different kinds of baths, and we still do this today. Athletes do ice baths after working out. So in of itself, this is the purpose of giving this example is to show you something that maybe you or I may not want to do. And we might say, okay, yeah, there's only a segment of society that actually wants to do that. It's still not abnormal. It's still not a disorder. Does that make sense, George?
Yes, it does. Thank you.
So, and especially, I'll build on to your point, especially if we're dealing with a person who that's part of their cultural value set, right? I know Turkish bathhouses exist and Russian bathhouses, and there are different kind of styles, right? And that's culturally acceptable. So yeah, long story short, no, the concept of icebreakers or ice baths would not be a disorder, even if we might find it deviant. Now, so we talked about deviance, distress, dysfunction. Dysfunction refers to somehow this is going to impact this person's ability to perform one of their life tasks. For example, does this condition impact one's ability to do well in the classroom, right? For an example of that might be ADHD, right? A person may struggle with attention and perform poorly. Does this condition affect one's ability to maintain housing, or does it affect their legal status? Does it affect their romantic relationships, their work performance, their relationship as a child or a parent, and so forth? You get what I'm trying to say. So dysfunction means that some aspect of this person's life has to be impacted negatively by the condition. And the last of the 4 Ds is danger. Danger, we talk about it causing harm to oneself or others. Now, if you think back to what I said, all of the psychological disorders must have the first 3. Not all disorders have danger. So there are certain conditions where a person can potentially be a harm to themselves or others. So if a person has severe depression and they become suicidal, that would be a risk for self-harm.
Frankie, you want me to help you with your homework?
I'm not sure who that was, but can you mute your mic if you could? Other conditions, a person may be homicidal and have thoughts of harming other people. But the average condition does not always have self or other harm. So things like an anxiety disorder rarely come with danger to the person or others around them. Things like a learning disorder, right, rarely come with harm to others or oneself. But there are some, like I said, things like depression, things like substance abuse, things like schizophrenia, and things like eating disorders can potentially result in a higher risk to self-harm or harm to other people. So let's talk about a condition that was in the DSM up to the DSM-3. 1973, it was taken out, and that is the condition of homosexuality. For a long time in our history, homosexuality was considered a psychological disorder. And eventually we came to realize that it wasn't a psychological disorder. Using the 4 Ds, we can actually prove this. So let's go through the 4 Ds again with the mindset of homosexuality. So deviance. So is engaging in homosexuality a deviant act? Well, if we were to look at it, and I'm taking religion out of this, because if we use religion, religion has its own perspective. So I'm using the prism of science. We estimate that anywhere between 10 to 20% of people in our society identify as part of the LGBT plus community. Now, that percentage may seem like a numerical minority. So you're like, well, if it's a numerical minority, then that's deviant. I would push back by saying there are other identity factors that are of a lower percentage in our society. For example, I identify as Jewish, and the Jewish population is about 2.2% of the US population, right? So by definition, being Jewish, does that make me deviant? Most people would say that's ridiculous. But by percentage, it's a very small minority. And yet you would respond, no, that's not deviant. Well, being part of the LGBT community has a higher percentage. There are more people identify with the LGBT community than people identify as Jewish. So just to give you that sense. But let's say you wanted to stick to the numbers and say that it is a numerical minority, and I couldn't convince you that it wasn't deviant. Distress. If you were to ask the average person who is part of the LGBT community, are they bothered with the fact that they identify as lesbian, gay, bisexual, trans, gender, etc.? The typical response would be no. Most people are not bothered by being part of the LGBT community. So here we're already starting to see the framework of a psychological disorder fall apart. Now, there are some people who struggle based on other religious or cultural value sets that they might struggle and be bothered that they identify as part of the LGBT community, but that's not the norm. There is distress being part of the LGBT community. In fact, members of the LGBT community have higher rates of suicide and self-harm. And you might say, well, if they're not bothered, then why is there higher rates of self-harm? The answer is that being a minority group comes with persecution. If you ask, am I bothered with myself? The answer might be no. If you ask me, are you making me feel comfortable being who I am, or are you rejecting me? The answer might be different, right? So distress might come from outside of the person, not within. So we're already seeing that it's hard to put individuals into a disorder if they identify as part of the LGBT community. Now, let's say you wanted to still take words I've said before. Oh, but you said with substance abuse, that person may not be bothered and other people might be bothered. So you said, no, I still want to argue that there is some distress. Here's where it completely falls apart. When we look at dysfunction, are people who are lesbian or gay or bisexual and so forth any worse at being a brother or a sister? Any worse at being an employee? Any poorer as students in a classroom and so forth? There's no area of life where people who identify as lesbian, gay, bisexual, transgender are poorer in terms of their ability to perform that life task. So there's no real dysfunction. And historically, there was a time where people who were lesbian or gay struggled to adopt children because there was this homophobia that somehow if you're lesbian or gay, you're going to harm the child or you're going to be poorer as a parent. Well, that has disappeared. That argument has disappeared. And what we find is that in reality, people from the LGBT community are equally competent as parents. They do not cause greater harm to their children. And the rates of identifying as LGBT in children or among children who have LGBT parents is the same as the previous generation. So the belief that, oh, you're going to push it on the child, even that's false. So by 1973, we were like, yeah, okay, it doesn't fit this prism. But keep in mind, before the DSM-3, a lot of the ideas were influenced by psychoanalytic principles. So Freud did view homosexuality as pathological, right? So once we broke free from Freudian ideology exclusively, we were able to remove homosexuality from the DSM. I share this story with you because I want you to understand that there is a framework, there is a prism, and we are very careful as to what we include or exclude from the DSM. We use scientific rigor to evaluate what could or should be included. And if we don't have enough evidence to include something, we also have a section in the DSM called conditions for further study. When you have a condition for further study, we're saying we're not sure yet. We don't have enough science to answer one way or another. But what is really cool about the DSM is it's constantly evolving. So things we previously would have stigmatized or listed as a psychological disorder, they can be removed from the DSM if we deem, based on the scientific evidence, that category or that diagnosis was incorrect. So that's a thought there. Any thoughts, reaction to my discussion about the 4Ds as a framework for disorders and the historical case of homosexuality and how it wound up being removed from the DSM and looking through this prism? Okay.
I just have a quick question regarding, well, the DSM. Who is it that decides if something qualifies or doesn't qualify as like a mental illness, or, if it aligns with the, the 4 words that we just learned? Who is it that decides that?
I love the question. So if you ever purchase a DSM, you will see that every section of the DSM had a think tank, a series of scholars in the field who are vetting the conditions that they're an expert in. So it is a criticism, by the way. Your question is a beautiful criticism. And one of the controversies of the DSM historically is that the group that worked on the DSM may have had their own biases. So I love the question. Right on with that. But so there are several hundred clinical experts that are part of teams, right? So you might have a task force on eating disorders, and you bring the foremost international experts together, and they evaluate the state of the research on the condition. And they come together to decide, yeah, this should be included, this shouldn't be included. And then before the DSM is published, there's also a public commentary period. So if they come to decide that this condition might be a condition to include, they'll throw it out to the clinical community and say, here's what we're thinking. What, anyone have a comment or reaction to this? So they put it on the American Psychiatric Association's listserv. The American Psychological Association is part of it to some degree. And then there's kind of further commentary. Now, one of the things I will tell you is that the task force can choose to accept or reject the commentary, but at least there's more feedback in it. Interesting to note, if you look at the DSM-5, there are some people who feel that it actually has gone backwards in some ways. There are some people who have criticized the DSM-5 in terms of its sensitivity to diagnosis relative to previous editions. So I know in the DSM-4, there was a very strong support for it, and its ability to diagnose was strong. In terms of the research on diagnosis, it's dropped off a little bit. Not much, but a little bit. But that's enough to offer some criticism of the current DSM. Now, I love the question, Eileen. I hope I gave you a full answer.
Yeah, definitely. Thank you. That was great.
And I will say something else while I have you guys as thinking about this. The fact that there is a DSM-5 implies that there was a DSM-4, 3, 2, and an original DSM, right? It's in its 5th edition, means that we needed to change it at least 4 times over. And what I will promise you is that if there's a 5, there will be a 6. Right? So because science is constantly evolving, we want to be as true to where science is as possible. We want to be fair, and we don't want to over pathologize, right? That's one of the biggest things. I will tell you that one of the nicer things about the DSM-4 and the current DSM-5 is that there is a greater focus on cultural sensitivity and really trying to understand cultural variations. So for all the criticisms, that's one of its strengths. All right, so those are the 4 Ds. Now, I also want to be objective in how I teach, because even though I am a clinical psychologist and I use the DSM as a framework for diagnosis, there is a whole movement called the Antipsychiatry movement, who want to do away with diagnoses as a whole. So there is a movement that pushes against diagnosis. And one of the criticisms is that diagnoses are stigmatizing, and there might be an overuse of diagnosis. So that's one criticism. But there was this really cool criticism that I want to introduce you to. There was a gentleman by the name of Thomas Saz who argued that the whole concept of mental illness should be thrown away. The whole concept. So if Thomas Saz had enough traction, we would get rid of this whole class in principle, right? And what does Thomas Saz argue? He argues that what we are labeling as abnormal are really just problems with daily living. That's what they are. And what we are pathologizing are just day-to-day struggles. So the more we pathologize, the more we stigmatize. He further argues that what we view as normal or abnormal is based on a pretty Eurocentric societal view, right? So our understanding of normal may differ in another society, right? So societies like ours might use diagnoses to push people down, to stop people from moving forward in society, or to control people or gain social order. So Thomas Saz has an interesting argument. And while I personally disagree with it, right, as a clinician, I think it's a little bit too extreme. I understand his point. I want you to understand the other voices, right? So if you're going to be critical consumers of information, I can't just teach you what I believe. I want you to understand the other points of view, right? So there are people who push back on diagnosis as a whole. So remember the name Thomas Saz. So this is kind of our starting point as it relates to understanding the framework of psychopathology. So here are some other things you might want to think about as well, is that even if we came to an agreed upon language or concept of what to diagnose, and that's the goal of the DSM, is to give us a framework, a common language, common knowledge, allows professionals to speak to one another and understand each other's framework. We still see that disorders are not applied consistently across the board. For example, if you go to college health centers, you might see a higher diagnosis of alcohol use disorder in colleges relative to other communities. And you might see an overdiagnosis of an alcohol use disorder, when in reality, this is part of college life. You see that people tend to experiment with alcohol. There are fraternities and sororities and house parties that that there is a higher exposure to alcohol, but without a careful clinical assessment, you might diagnose someone with an alcohol use disorder more than one should. Another interesting thing is that, remember I said psychological disorders are diagnosed both in the rich and the poor. That is true. But what we do see is higher rates of mental illness among people who live in poverty. And one might ask, is this a true representation of where psychological disorders are? Or are we over pathologizing people who have financial limitations? Another question one might ask himself is, how do we differentiate between a person who has a mental illness versus a person who is just eccentric, right? So being eccentric means that the person is peculiar. They might behave in what we might view as odd or whimsical behavior. For example, if I can use Beauty and the Beast as an example, and Belle's father. Did Belle's father have a psychological disorder? Or was he kind of this quirky, eccentric inventor? The reality is he was just an inventor. Nothing in the movie suggested that he had a mental illness. But that didn't stop people from trying to pathologize him. And in the movie, you see, I guess, Gaston arrange Belle's father to be picked up and sent to an asylum. We have to be able to differentiate between people who are quirky eccentric, odd, but not pathological. We have to be able to do that. So I bring this up as well because I really want you to understand that as much as we want to adhere to the science of diagnosis, there is still some judgment. There is still some kind of art or clinical assessment that has to be done. And if you're not careful, you could over pathologize. Jessica.
Oh yeah, I just had to. I was gonna put an input because that was like a good example, and like me who's just learning this stuff, I was kind of confused. Like it makes sense that some people think that people that are like what you said over like like are very excited or whatever the case may be are like different and might have like some kind of like disorder with them. But I never viewed it as like, no, they're just like normal people. They just have this other side of their personality that's just like,
And you talked about a person who's like overly energetic. Well, a person might think that they're engaging in a manic or a hypomanic episode and want to diagnose this person with bipolar disorder. When in reality, you can only do that with a careful assessment and a determination that somehow this overexcitement is resulting into some kind of harmful behavior, whether it be impulsive spending, reckless sexual activity, things like that. So yeah, just being like super energetic is not enough to diagnose a person. So I appreciate your example as well. All right. So that is, the framework of abnormal behavior. Now I'm going to stop